I think the main challenge for NTM PD diagnosis is to succeed to do this diagnosis as clinical and radiological signs are unspecific. That is why on the first side the risk is underdiagnosed because patient needs multiple positive samples and it's not always done. So diagnosis is delayed and treatment is delayed, and it exposes patient to have a destruction of his lung. On the other side, as clinical and radiological signs are unspecific, the main criteria for the diagnosis is to exclude the most probable diagnosis than NTM PD. So if we do a too early diagnosis, we risk to treat very early, and so to expose patient to toxicity to the treatment and to expose patient to the progression of another disease like lung cancer. The other management is the other challenge is to do the good management of this patient. I think it's because these clinical and radiological signs are very unspecific, and the disease occurs in patients with chronic respiratory disease like COPD and bronchiectasis. So it's not easy to distinguish COPD acute exacerbation to NTM PD to another pathogen infection or to another disease like lung cancer. So for clinicians it's very difficult to do the difference, so to do the diagnosis and then to decide to treat. And I think it's important that they discuss with expert centers for the diagnosis and then to decide which treatment to do to the patient. So the most effective, I think, is first to discuss with expert centers to decide who has to be treated, when and how. And when we decide to treat, we need at least 3 or 4 drugs, and we have to avoid monotherapy. If we have monotherapy, especially macrolized monotherapy, we will select multi-drug resistant strain, and it will be very difficult after to treat. On the second hand, we have to follow the sputum to know the date of the sputum conversion, and so to decide how long the treatment will be used by the patient. The main limitation is that the optimal treatment for NTM is unknown today. We have to use a multi-drug regimen for a long time. The treatment is difficult with a lot of toxicity for the patient. And so patients start treatment but have adverse effects and they stop and discontinue the treatment. So we urgently need new drugs with less toxicity and much more efficacy. So we are lucky because there are some new drugs which are tested actually. One is a specific NTM drug, which is inhaled amikacin liposomal, and it was tested in 2 clinical trials. Even if they did not reach the significance for the main endpoint, it seems that it improves the sputum conversion. It was tested only in refractory MAC disease, and probably some other studies are necessary to well know which patient could benefit of this treatment. And there is some other drugs, maybe mainly TB drugs, like beta-acylin, tedizolide, and a very old drug like clofazimine, which are evaluated, but it's only in case series or in cohort. We have no randomized study. And some drugs are in the pipeline, but they are only at the in vitro or murine model stage, so it's not for now, and we urgently need new drugs for our patients.